Hello, my name is Matt Lyon from EUS Academy. Today's lecture is entitled Ultrasound Guided Peripheral IV Placement. Our objectives are to describe how ultrasound is used to make pictures of internal body structures, to list the uses and indications for using ultrasound peripheral venous access, to describe the technique of actually placing the catheter in a vein using ultrasound, to list common mistakes and how to avoid them when using ultrasound for vascular access. Peripheral IV insertion using ultrasound requires a basic knowledge of the principles of ultrasound. This includes some knowledge of ultrasound physics, how to turn on the machine and set up the machine, so machine controls, how to set up and prepare yourself as well as the patient for placement of an IV catheter using ultrasound, and then the peripheral IV placement methods. But first, why would you want to know how to do this? Well, all of us have been in this situation where we've had patients where we couldn't get peripheral venous access using a blind technique. And patients have poor satisfaction when you have to stick them multiple times and still haven't obtained their blood or placed that IV. We've been doing this technique for about 12 years now. And one of the reasons why we started using this is because our radiologist insisted that we use 18-gauge IV in the AC for CT angiogram. And that's very difficult to do in some patients, particularly when you have a subset of patients that are very sick that require this. So we began using ultrasound for vascular access, and it's become a very good technique, and a lot of our nurses use this as well as our physicians, and our central line rate has decreased greatly. Part of the reason for using ultrasound guidance is because we deal with people that are obese, and it's difficult to find landmarks or find the vessel just using our fingers or using our eyes. Then we also have patients that have AV shunts from end-stage renal disease, and they have limited places where you can place vascular access. And we have patients that either through IV drug use or through medications because they're sick have limited veins in their forearms, and so vascular access can be very difficult in a large percentage of our patients. We did a study looking at this a few years ago, and we found that body habitus was the most common reason why people failed at getting blind vascular access. But chronic medical conditions such as cancer or sickle cell came in a close second, and then dialysis, vascular disease, and IV drug abuse also contribute to this. So we found that if you add ultrasound guidance for vascular access, you decrease the number of attempts for IV access. You have increased speed, and you would think that if you had to set up and use another tool that it may take you longer, but really, with experienced nurses, after you've been doing this for a while, the average access time is less than a minute, actually much less than a minute. We'll see that at the end of the lecture today. You have a high success rate, so in patients that have had failed peripheral venous access using the blind technique, 86% of the nurse was able to get IV access using ultrasound. And so we have had a much decreased use in our central venous access. You also, because of this, you have improved patient satisfaction because you're not being stuck as often. And then really you have an improved nurse satisfaction, which is really a big thing also. So how does that ultrasound work? Well, ultrasound uses waves of sound to make a picture. These waves of sound are very high frequency. They're beyond your hearing. And so since it uses sound, there's really no maximal dosage for ultrasound, but it may cause tissue heating. Now, the ultrasound uses a machine to make the pictures, as well as a transducer, as you see down here on the screen, for sending the sound waves into the body. This transducer acts both as a speaker, sending out sound waves in the body, and as a microphone, listening for the reflected wave coming back from the body. So as the sound enters the body from that transducer, it strikes various surfaces. These surfaces can be the skin, muscle, blood vessel walls, the blood itself, or maybe bone, as well as maybe the needle. As it strikes these surfaces, part of the sound is reflected back and part of the sound is transmitted. All right? So if we look here, part of the sound is coming into the body, it hits a surface, part is reflected, and part is sent on to image deeper tissues in the body. It's this reflected wave the transducer is listening for to create the ultrasound image. So you can think of it like this. If the sound wave strikes something soft like water, very little of the signal is reflected, so it looks dark or black on the screen. If it strikes something hard like bone, most of the signal is reflected, so it looks bright or white on the screen. All right, so you tell what things are or how much water content they have as to being how dark they are or black, or how bright or white they are on the screen. Here's an unrelated example to what we're talking about today, but this is a gallbladder and it shows all these principles. If we look, we see this very dark structure on the screen. All right, and since it's black, we know it's a fluid-like structure. In this case, this is the gallbladder, and it is filled with fluid, gallbladder fluid, so it is black on the screen. Inside this gallbladder are two gallstones, here and here. These gallstones are bone-like, so they're very hard. Since they're hard, they produce a very bright image. In this case, bones, for the most part, produce so much reflection of that signal that there is loss of signal behind it, which creates this shadow or black behind it. So we see that bone is bright and then has loss of signal behind it, or shadow. Everything else on the screen is a shade of gray. And the darkness or the blackness, the deeper the gray, the more fluid that structure has in it. So if we look here, this is the liver, and the liver is a dark gray, and we would expect that as the liver is filled with blood. If we look at the gallbladder capsule here, it's fairly bright, and you would think that the gallbladder capsule actually has very little blood in the capsule itself, so that's why it's bright. But it's not bone-like, so it doesn't reflect all the signal, so you do not have shadowing behind it, and you can see the things deep to the gallbladder capsule. Here's a more relevant example. This is a blood vessel. It's filled with fluid or blood. Since it's filled with fluid like water, it is black. So blood is black like fluid or water. This is a bone, so it's very bright, and it's cut off on the screen here, but it's causing a shadow behind it. And everything else is a shade of gray. So we have some muscle and fat up here, which is one shade of gray. We have another area of muscle back here, which is a darker shade of gray because it has more fluid in it. And so we can tell what all the structures are by just looking at the amount of gray and how bright or dark the image is. So again, blood is black, bone is bright, or maybe a needle is bright, and everything else is a shade of gray. But remember, all fluid is black. So you can't just look at the fluid and tell what it is by how black it is, because all fluid is black. So in this example here, this is actually a finger in a water bath, so this is water and it's black. We saw this example before. This is a blood vessel, and it is also black. And then here we see some black fluid, and this is actually an ovarian cyst. Again, it's black. So you can't tell what kind of fluid it is by just looking to see how black it is. Furthermore, you can't tell the difference between arterial or venous blood by just looking at it. There's another technique we're going to do to tell the difference between an artery and vein, which we'll talk about in a few minutes. Now, sound waves are made by the ultrasound probe, and what probe you use depends on what you're going to image. But for vascular access, we always use the linear probe or flat face probe. So look at this probe. It has a flat face, and the beams come straight out and straight back. So it's not curved, so they're not coming at an angle, so straight out and straight back. And when they do this, they produce a nice rectangular or square image. All right, so the beams are coming straight down and straight back, and here's a blood vessel. And because the beams are coming out of this flat face straight out and straight back, objects underneath the transducer, which are straight, like a needle, will appear straight on our screen, which is very advantageous for us. Now, the majority of supplies for peripheral venous access, whether it's blind or using ultrasound guidance, are almost the same. There's a couple exceptions we're going to talk about in a minute. Since this is a peripheral venous access, we use aseptic technique for prep. We don't have to use a sterile technique, even though this is going in a little bit larger vein than what we typically use for blind venous access. Now, here's a couple differences. All right, so we need to cover up this transducer or probe. This probe could have been used for draining abscess. It could be contaminated. I typically clean the probe prior to using it on any patient, but we want to have an extra barrier for protecting our patients. So what we use is these sheaths. That's a non-latex rubber sheath, and we use it to cover the probe. Now, air is our enemy when it comes to ultrasound. Our ultrasound beam doesn't image through air, so we have to couple the ultrasound transducer to the skin with a coupling medium, and in this case we use ultrasound gel. But ultrasound gel typically comes in a big bottle like this big bottle of Aquasonic. Again, this bottle of Aquasonic could have been used on a patient that had abscess and maybe is covered in MRSA. So for vascular access, we use these individual packs of lubricating jelly, which are fairly common in the emergency department, used for many uses. The lubricating jelly actually has an advantage of not only being sterile, but also being bacteriostatic. So this is our choice for using on patients. We're using ultrasound-guided vascular access. Now you have to put the gel underneath the sheath, so put the gel on the probe, then put the cover on the probe so that there's no air underneath the sheath, and then put the gel on top of the patient also. So again, we don't want any air interfaces. Now there's lots of machines that can be used for ultrasound-guided vascular access, and you may have a dedicated machine for this, or you may be using a more general machine. And it really doesn't matter. As long as it's an ultrasound machine, it will make the same image as long as you use the correct probe, which again was that linear or flat face probe. Now, one of the most important steps of ultrasound-guided vascular access is your setup. It's really important that you set the bed so that you are comfortable. As we see here, she is sitting down and has the machine at eye level and her hands in a comfortable position so that she is very well braced and not uncomfortably leaning over and straining her back. It's important, though, to set up the machine so you look down at your hand and up at the machine, down at your hand and up at your machine. If you have to turn your head to the side every time you want to look at the machine or your hand's going to involuntarily move when you turn back towards the machine if it's off to the side. And this causes you to look down at your hand and think you're somewhere, and then when you look at the machine, it's in a different location. So set it so that the machine is right in your line of view. So up at the machine, down at your hand. This may mean that the machine is across the patient. It may mean it's at the patient's head. It may mean it's on the other side of the bed. However you have to do it, just to make sure you look down and up. And then also brace your hand. People typically begin holding the transducer up near the cord because down here is that ultrasound jelly, and they don't want to get their hand in that ultrasound jelly. But if you hold the probe up high, you have very little control, and this procedure takes a lot of fine motor control. So the lower you can hold it, the better. I typically hold it right at the face of the probe so I can feel the skin and the probe at the same time. She's having a hard time doing that because she's sticking her needle right underneath there, so she's got her hand elevated a little bit, but notice that she's also bracing her needle hand too. So brace your hand on the patient, hold the probe as low as you can, and place the needle right underneath the probe, which we'll talk about in a few minutes, but brace your hand on the skin. That way, without looking at your hands, you know where your hands are, your probe is, and also where your needle is, all at the same time. Now, probe movements are very, very important. And generally, when we're looking at an ultrasound created image, we're looking at a 2D image, so depth and length or depth and width. So you have to pan the probe side to side or up and down to create that 3D mental image. In cross-section, if we place our probe across a vein, we'll see a cross-sectional image, and when we do that, this vein looks like a circle. But we have to move the probe up and down the vein to see how that vein changes in the skin. If we never move our probe, then this image never changes. It's the same CT scan slice. And we see that as we move it up the vein, it becomes more superficial, and we can build that 3D mental image by compiling all of these CT scan slices into a 3D mental image. If we do longitudinal, or where we're in parallel to the vein, if we're directly over the vein, we see the vein in its entirety, from top to bottom or from proximal to distal or however. But if we're off on one side or the other, we don't see anything. Note that this beam coming out of the transducer is about as thin as a sheet of paper, so you must be directly over the vessel to be able to see the vessel. Again, if you're off on one side or the other, you don't see anything. Now, there's two methods of imaging a vessel which we've really already talked about, and they're called transverse or cross-section, and I may use those terms interchangeably, where the probe is perpendicular to the vein and it looks like a circle, or longitudinal or long axis, where the probe is parallel to the vein and looks like a tube or a thick line. Now, no matter how we're going to end up imaging our vessel, we always start off in transverse or cross section. Now you can imagine that in long axis, if you're off on one side or the other, you don't see your vessel. Well, in transverse, no matter how you start, you're always going to see your vessel. If there's a vessel there and you're transverse, you always see the vessel. All right, and it looks like a circle. So here's the internal jugular vein. It looks like a circle. And the way we determine the difference between an artery and vein is by using the compression technique. So we use the transducer, we identify our vessel, it looks like a circle, and we press down with the transducer over the vessel, as we're doing here. So we push down with the transducer and we see that this vessel is collapsing easily, so it's a vein. The artery is collapsing some when we push hard enough, but it's a much higher pressure vessel, so it takes a lot more force. This is also a vein over here. It's collapsing easily. These little dots at the top are nerves, so they do not collapse no matter how hard it's pushed. For venous vascular access, generally the rule of thumb is if it doesn't collapse easily, then it's not an appropriate vessel for vascular access. So we see here this vein is collapsing very easily, so it's an appropriate vessel for vascular access. There's one caveat here. Nurses often use tourniquets to make the vessel become bigger. Well, when you put a tourniquet above this vessel and there's a valve more distally, when you do the compression technique, there's no place for the blood to go, so a normal vein may not collapse readily if there's a tourniquet in place. I typically do not use a tourniquet for venous vascular access because of this. Now, since we can look at our vessels even before we stick the patient, it's best to go on and survey before you set up what's the most appropriate vessel for vascular access and where you're going to stick before you even do anything further. So if you were looking at this picture with two vessels, all right, they're both veins, but if you look at the top one, it's bigger and it's superficial. So it would probably be the ideal choice if you're going to pick between these two. This one's a little bit deeper, a little bit smaller, would be a little bit more difficult of a choice, but it's certainly a reasonable choice if you didn't have this bigger one sitting there. But you can also slide up and down the vein. Remember, we're going to make that 3D mental image, and as you start making that 3D mental image, what does that vein do? We notice that the bigger, more superficial vein immediately bifurcates into two veins. So maybe that'll cause us some problems when we're trying to feed our catheter. Maybe you see a big valve there and you want to go above the valve. Plan out your route of your catheter before you even stick the patient to know that you're going to have a successful procedure. Now, the general technique for ultrasound-guided venous access does not depend on the vessel being cannulated. And there's two approaches for cannulation, and they're the same name as for image acquisition, so transverse or cross-section and longitudinal or long axis. Now, no matter how we're going to end up imaging the vessel, we always start out in transverse or cross-section. One, we can identify the vessel very readily because we're always across the vessel, so we always see the vessel. And then two, we can do the compression technique so we can identify vein, two veins here, versus the artery. All right? Now, for the transverse approach, we place the probe across the vein. So this is a simulated arm. So the probe is across the vein. So it's going to look like a circle, and we place the needle under the long face of the probe. So here's the needle under the long face of the probe. So again, the vein is going to look like a circle, 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 compresses easily with compression, and the needle is going to look like a dot. So here's a bright dot heading right towards that vein. Here's a bright dot inside the vein. All right. So what we do is we're going to guide this needle down to the vein and have it sit right in the middle of the vein. In transverse approach, again, the vein is going to look like a circle, and we have to move our probe to see how that vein changes. If we don't move our probe, we never see a different image of the vein. Same is true for the needle. Once we put the needle into the skin, if we don't move the probe, then the image of the needle never changes, and instead of imaging the needle tip, we're imaging the needle shaft. So we must move our probe up and down the vein as we slide the needle into the skin. Let's see what this looks like schematically. Here we have the probe across the vein. So we see the vein as a circle, and we have stuck the needle as close to the probe as possible, as superficial as possible, right underneath the probe, and we see the needle as a dot. Now, everybody will make the mistake of sticking the needle way back here. If you stick the needle way back here and you're not inserted into the skin very far, you will not see this dot at the top of the screen. So, Stick the needle as close to the probe as possible. If you can't get real close, slide the probe back to the needle. You don't want to move the needle without seeing the needle tip. So we're looking at the needle tip right now. All right, this is the needle tip. It's close to the probe, as superficial as we can make it. Now, we're going to slide the probe till we can't see the needle anymore. That way we're not looking at the needle tip. Then we're going to slide the needle. So probe first, we don't see the needle. Now we're going to slide the needle into view. And there it is. As soon as you see the needle tip come into view, stop moving your needle because that is the needle tip. All right, now slide your probe. You can't see the needle anymore because we're beyond the tip of the needle. Now slide the needle into view, and there's the tip of the needle. All right, it's right on top of the vein, but don't go any further. Slide the probe. Can't see the needle tip. Now slide the needle tip into view. All right, that's how you do this procedure. Let's look at it one more time. The needle as close to the probe as possible, as superficial as possible. Now slide the probe till you can't see the needle anymore. We're beyond the needle. Now slide the needle into view. Needle comes into view. Soon as you see the needle, stop moving the needle. Because if you move the needle, you're only seeing shaft of the needle and not the needle tip. And we really care about the needle tip. So slide the probe. Now slide the needle into view. There it is. It's almost on the vessel, but hold tight, hold tight. Slide the probe. You slid the probe. You can't see the needle anymore. Now slide the needle into view, and there you are. So let's see what that looks like on a phantom. So he's going to exaggerate his movements, all right, to show you that he's moving. It's actually a much smaller movement. It's not as big as that. All right. So as soon as he sees his needle tip come into view, there's his needle tip coming into view. Stop moving your needle. Stop moving your needle. Slide your probe. Now, watch the needle come into view. As soon as you see your needle tip come into view, then you move your probe. He's going to feed his catheter just to show you that it's in the vein. We're going to watch this one more time. All right, so start. It's close to the surface as you can get when you see your needle tip. Then move your probe. Needle comes into view. Move your probe. Then needle. Here comes the needle. Needle comes into view. Now slide your probe. Stop moving your needle. Slide your probe. Here comes the needle into view, right there, right in the center of the vein. That's all it is to it. But there's a lot of places for mistakes here because it's very easy to forget to move your probe, all right? So you're used to looking at the skin, looking at your needle, watching for flashback. So you image the vessel's here, and you stick your needle under, you see your needle come into the screen, you know it's lined up, and your tendency is just to keep on advancing your needle. Well, you're used to doing this in a blind fashion, so you're used to looking for a flashback. So you're watching for that, and all of a sudden you get a flashback. Oh, that's good. But you could be right in the center of the vessel. But often what happens is that you keep on moving your needle, and you end up in the back of the vessel. So on the first few you do, you're going to end up doing this a few times. And the way you know you've gone through the vessel is because the catheter won't feed. So when you have those times when you say, I keep getting into the vessel, I see it in the vessel, but then the catheter won't feed, it's because you didn't watch the needle tip, and the needle tip is actually deeper than you thought, and it's posterior to the vessel. It's already gone through the back wall. Now, in most cases, this doesn't have any bad effects. I mean, you're going to get a hematoma, and you may have to pick a different site, but on occasion, there's an artery back there, and you may get an arterial line, as we see here. So be careful. We need to see where the needle tip is at all time and not the needle shaft. So it's always probe, then needle into view. As soon as you see your needle, then you move your probe, then needle. It's a stepwise procedure. Now, this is the central vein. This is the internal jugular vein, and this is the carotid. And the reason I wanted to show you this is because this is the way not to do it. All right. If you look at this cross-section of the thyroid and the carotid, this image never changes. This is always the same image. They're not moving their probe. Now, we can see that the needle is indenting the vessel. We can see that we're over the vessel. They were looking or feeling for a flashback, and they never felt it because they popped through both walls at the same time. And so their needle is actually way back here. It's way deep. They never followed their needle. So I'm sitting there and I'm telling this person, pull your needle back, you're way too deep. Could have said, slide your probe down and find your needle. But in this case, pull your needle back. You can see how it's through the back wall. That's still needle shaft. They're still pulling it back, pull it back, pull it back. Come on back some more, come on back some more. And there's the needle tip sitting now in the vessel right there. So they finally got it after all that. So you must follow your needle tip as you go through this procedure. Now the other technique is called the longitudinal or long axis approach. And with this, we always start transverse, identify our vein, but then we rotate our probe so that it's parallel to the vein. And when we do that, we place our needle underneath the short face of the probe. If you look, there's a seam running down most probes, and we try and put our needle directly under this seam. Alright, but the most difficult part of this procedure is actually rotating from short axis, or cross-sectional, to long axis. Alright, and this takes a lot of practice. Notice how he is rotating slowly. You keep the vessel that you're interested in on the screen at the whole time, because once you identify it in cross-section, you can't re-identify it in longitudinal. Because remember, if you're compressing to see if the vessel's collapsing in cross-section, if you tried that in long axis, is the vessel collapsing or are you sliding off to the side? Remember, because if you slide off to the side in long axis, the image disappears because you're not directly lined up with it. So the most complicated part of this procedure is this rotation from short axis to long axis. But when we do that, we see it's the vessel in its entirety. So here's the entire vessel, whole length, and we can see the needle in its length, and we can guide it right towards the vessel. So once you are able to rotate and get the vessel lined up, the needle and the vessel are seen in its entirety. You know that you're directly over the vessel when the walls of the vessel are very bright. See how bright they are here? You know you're directly over the vessel. If you look here, the walls are not as bright, and it seems to be some filling in of this soft tissue. This is a phantom, but this soft tissue. This means that you're slightly oblique at this part of the vessel. You're not directly over the center of the vessel, and you're getting a little volume averaging artifact. Just remember, if the walls are bright, you're directly over the vessel. Same with the needle. When the needle is directly in the plane of the beam, it is very bright. Again, the problem here is if you're not directly over the vessel, you won't see the vessel. So if you're off on one side or the other, you don't see the vessel. If you're directly over the vessel, you see the vessel in its entirety. So when you rotate, you have to rotate completely 90 degrees from short axis to long axis so you can see the entirety of the vessel. The walls will become really bright. Now, you have to get the needle in this plane. Remember, this plane is as thin as a sheet of paper. You have to get the needle in the same plane with the vessel. That is quite hard to do. So oftentimes, you have the vein nice and lined up. You did a good job on that. You stick your needle underneath the transducer as close to the center of the transducer as you can, but you're off on one side or the other. That's not a big problem. You're barely off. We're talking about as thin as a sheet of paper off, maybe a half a millimeter off. All right? So you have to pan the probe side to side to find where your needle is. So you pan it over. Oh, here's my needle. You pan it back. There's my vessel. Pan it over. There's my needle. Here's my vessel. Okay? When you figure out where your needle is, you have to redirect it back towards the vessel. So I need to redirect my needle from 3 back over to 2. So I line back up on the vessel, I redirect my needle back towards the vein, and as I do that, the needle comes into view because it's entering that sheet of paper thickness beam, and it's becoming very bright. As it gets into the beam, it becomes brighter and brighter, and I guide it towards my vessel. So this is what it looks like. Here's our vessel. You can tell that the walls are bright. They're not so bright down here. We're not lined up here. We're lined up here. And when the needle came in, we're going to watch this repeat again. When the needle came in, it was not very bright. It was dull. It was not in the same plane. So they panned over. They found this needle. It was just a little off the out of plane of the beam. It was on the other side of the screen, if you can think of it that way. And they're directing it back in towards the screen. And as they do, the needle tip is becoming brighter and brighter. See how bright that needle tip is? And it's sitting right in the middle of the vein. So that's how we do this procedure. So here's an example. This is one of our former residents. We're not actually going to stick him in the neck, but we just want to show you how to do this. And this is actually a central venous access, which is just easier for demonstration because it's a bigger vessel. So my partner is going to place the probe across the patient's neck, all right, because we want to start out in cross section. So when we place it across the neck, we know we're going to see the vessel. In this case, here's the IJ vein. He just showed you that it collapses easily with pressure. He's doing the long axis approach, so he rotates to a long axis. The walls are very bright. He sticks his needle under the short face of the probe. When we do that, he lined it up very well. And here comes the needle. It's a little dull, but it's getting brighter and brighter, and it enters the vessel. All right? This is how we do this procedure. Again, one more time, we put the probe across our vessel that we're interested in. We're going to identify our vessel, our potential vessel. Then we're going to assure that it's a vein by doing the compression technique. Once we know that what we're looking at is the correct vessel and is a vein, then we're going to rotate the long axis. So here we are, we identified, we did the compression technique, we're rotating the long axis. We're going to try and make the walls as bright as possible because we know we're right over the center of the vessel. And we're going to take care to place our needle right underneath that seam of the probe, and when we do that, we can see the needle come right down into the vein. So which technique is better, the transverse or long axis? Well, transverse is easier to learn because you always see the needle and you always see the vein. The problem is that you can get a false sense of security because you think you see the needle tip when actually you're seeing the needle shaft because you're not moving your probe. And so you can cause damage by either going through the vessel or causing a hematoma or going into an artery that may be posterior to the vessel. But the real pitfall is that you don't actually get your cannulation, and it can be frustrating. So you must move your probe, then needle into view. Probe, then needle into view. In long axis, you see the entirety of the vein and you see the entirety of the needle. And if you line it up correctly, you don't have to move your probe. But it's more difficult because you have to line up three things: the probe, the vessel, and the needle. And remember, that beam is as thin as a sheet of paper. So you may not line them all up initially. So you may have to pan over to the side and find your needle and then pan back to your vein and redirect towards the vein. It's really probably a safer approach to use long axis, but it does take more practice to be able to do this. Now some specifics on peripheral venous access. A vein is a vein, and veins have names, but everybody's veins are a little bit different, and names do not make a difference to us. Now, we tend to use the basilic vein in the upper arm because it's often less scarred and it's almost always present, so it's an easy vein to use. But you can use any vein in the forearm, the mid-arm, or the upper arm. They're all the same, and this technique works for all of them. So you don't have to be concerned about exactly where the vein is and which one you're going to use. Now, the exception to this is the antecubital vein, and because it is a superficial vein, it's difficult to image with ultrasound because it's very, very superficial on the screen, so it's at the top part of the screen. And you don't have room to guide your needle into the vein because it's so superficial. So typically with ultrasound guidance, you use a deeper vein. And if they had a big antecubital vein that was easy to see, you probably wouldn't use ultrasound anyway. So we typically use a little bit deeper vein for ultrasound guidance, but a vein's a vein, and any vein you can find, that'll work. Now, upper arm veins are usually our best choice and the ones that I typically go for because they're almost always present, and they're much less affected by obesity and vascular disease and things we talked about at the beginning. So they're almost always present and patent and appropriate choice. And so they're rarely used for blind peripheral access, and so there's less scarring. So excellent choice. Now, there's several veins in the upper arm. There's the cephalic vein, the basilic vein. Any of those will work. The basilic vein is almost always in the same place, which is between the humerus and the biceps on the medial side of the arm. It doesn't matter. Any of the veins will work. You pick the vein, that's a good vein, and that's the one that I would suggest, but any vein will work. A vein is a vein. So here's one of our nurses. She's going to show you the technique from beginning to end. She put the gel underneath the probe, so that's eliminating air. She did get a little air bubble at the top of the transducer, and you would want to get that out before you start your technique. She's going to prep the patient as usual. See, she's not using a tourniquet. It's down here off to the side. She is using ChloraPrep and doing a wide prep. She's already mapped out where she's going to go, so she knows where she's going to go even before she did the ChloraPrep. She's identified her vein. She did the compression technique. She's rotating the long axis. And I had to slow the video down because she's so fast. She's very fast. So she's going to show you, she's going to do it in long axis. She has everything lined up. Here's her vein. She sticks the needle in. She's going to show you that she's in the vein. Even though she knew she was in the vein, she can see it. And she inserts her catheter. It's that fast. All right, one more time. So gel on top of the probe. Get these little air bubbles out by swiping them off to the side. Just use your finger and push them off to the side because air is our enemy. So move that little air bubble off to the side. Prep as usual. Identify, where you're going and make sure it's an appropriate target vein. I generally prep fairly wide just in case I have problems. I don't have to re-prep. I can just move to my secondary site if need be. Identify your vein. Start cross-section or across the arm. Make sure the vein collapses. Rotate the long axis if you choose to do the long axis technique. Place the needle as in the middle of the probe as possible. If you do that, you can see she was just a little off to the side, and as she brought it back in, and the needle tip got real bright, sitting in the middle of the vessel, and advance your catheter. And that's it. So again, I appreciate you listening to this ultrasound-guided venous access lecture today. Please visit us at eusacademy.com, and please contact me if you have any questions. Thank you.